So I think I'll make a start with the introductions, and I'm sure a few other people will join us as we go. And we are recording, and we do pop this up on our website, and find that we often get many more views after the fact. So yeah, thank you everyone who's here today, and we look forward to your engagement in the presentation and questions at the end, and a very warm welcome to our presenters who have gotten up very early, as the sun is just rising in Denmark, although the sun's probably been up for quite a while, given that it's getting closer to summertime over there. But we're really excited to have you with us today. So this is one of the Deliver series webinars. We're delighted to have been able to run a number of these over the couple of years that we've been running as a program, and I'm sure you'll get a lot out of the presentation today. I'd like to take a moment to acknowledge country, and as we gather for this meeting, physically dispersed and virtually constructed, I'd like to take a moment to reflect on the meaning of place, and in doing so recognise the traditional lands on which we're all meeting today and working across the country. I'm on the traditional lands of the Wurundjeri people of the Kulin Nations, and I acknowledge the elders past, present and emerging for all the land that we work and live on, and pay my respect to the ancestral spirits with gratitude and respect. And I pay my respects to anyone of Aboriginal or Torres Strait Islander background with us today. So before I introduce our two speakers, I just will give a really quick background to why we've invited Helle and Maiken to present to us today. So many of you are quite familiar with the Deliver program and the work that we've been doing, but some of you may have only heard little bits and pieces, and perhaps not quite across the detail as some of us are. But through the work that we've been doing across the western region of Victoria over the last couple of years, we've had a number of the team working with the health services to identify areas or actions or local solutions that they think will help to drive the uptake of home-based healthcare for older Australians living in rural and regional areas. One of the challenges that has been identified to really, I guess, increasing that uptake is digital literacy and digital health literacy. So certainly we see the use of digital tools and virtual tools as being an important part of being able to deliver more healthcare to people directly in their homes and their communities. And so this is a really sort of big challenge that we need to try and address to be able to maximise the opportunities that those tools present for delivering healthcare. And so a small working party was established across the team, and that's been led by Bodil Rasmussen, who's a professor at the Institute for Health Transformation, and also Dr. Olivia Metcalf at the University of Melbourne, who's a senior research fellow in digital health. And they've been leading a working party. And one of the first things they identified was that really the need to connect with experts in health literacy and digital health literacy to start to understand, well, what are some of the advances in this area, and how can we use some of their learnings to drive some of the work we might do forward in the project. So thank you to Bodil for inviting Helle and Maiken to present to us today. So Helle is a professor of health promotion in the Department of Public Health at Aarhus University, Denmark, and her main interest is in building capacity for health promotion in critical life transitions. She works on developing and evaluating health promotion and preventive interventions, primarily with a focus on health literacy and health equity. And then Maiken is a PhD fellow within the same department, but is also doing that as I don't know what the right term is, but like she's also a PhD student of the Institute of Health Transformation here at Deakin University, so like a conjoint appointment for her PhD. And I can't believe it was nearly probably 2-3 years ago that Maiken was in Melbourne and I was having coffee with her. So it seems that was just yesterday, Maiken. So I can't believe you've submitted your PhD, and we're super excited to hear and follow your work moving forward. Maiken, the focus of her PhD project has been on the intersection between pregnant women's health literacy and organisational health literacy. And she's really keen to understand how you can embed organisational health literacy responsiveness within healthcare systems to better serve diverse and vulnerable populations. So although her application has been in pregnant women, the learnings have a broader applicability across the health system. So delighted that you can both present to us today, and I'll hand over to you and look forward to some discussion at the end. Thanks very much.
Thank you. Thank you very much, Kate, and for the kind introduction. And we have divided the presentations a bit between us in a way where I will start with sort of giving maybe sort of a kind of a helicopter or a bit of an overview of the work we are doing in our research group, and not specifically diving into or digital health literacy, but the broader scope of health literacy and how we work with it also in a life course perspective. And then I think we will have 5 minutes or more to discuss my rather short presentation, and then I'll hand over to Maiken, who will dive much more into a specific group of a specific population of women, pregnant women, and she will dive much more into her analytic work that she's done for her PhD. And then we will again have the time for discussion and questions and so on. But I'm sure, Kate, you will take care of questions, and we don't mind interruptions, or hopefully we hope for a dialogue between our team and all of you. It's nice to see everybody this morning, afternoon, whatever, where you are in the world. Anyway, so I'll put on some slides and talk a little bit about them. I see screen one. Can you see my Can you see my slides now?
Yes, but it's in presenter view, so you might just need to switch the view.
It's not in presenter.
So we can see your notes.
And these notes may not be, they may not be specifically oriented for this presentation. I always have a lot of notes. I never use them. Is this better?
That's right. Yep, that's great.
Okay, so thank you for this invitation, and we are to move on. A little bit about our work here in Aarhus, because actually I'm affiliated to Deakin University as an honored professor, and I was way back in probably 10 years ago. No, yeah, in 2014, I think I was affiliated as also as an honored associate professor. And that was when we started working with numbers and epidemiological studies around health literacy. We have done a lot of epidemiological studies around health literacy using Richard Osborne's measurements around health literacy, but also European measurements and Nordic measurements. We have been diving into understanding the health literacy of quite a few, both sort of more general populations and also high-risk populations. And we've done quite a few qualitative studies, also, for instance, with Bodil Rasmussen and Anna Peters. But we have sort of over the years moved a lot towards the right side of this slide, because we have realized that we really wanted to act on these results that we got from health literacy surveys and so on. We wanted to make interventions and actually seek to change processes and for people, and we have done that by doing co-creation with some of our populations, and we have more and more moved towards the whole of system approaches, and that includes organizational health literacy. We have also worked on national and regional and local levels here in Denmark, and one of the sort of major change of capacity building that we have been involved in or have led has been working with the National Board of Health here in Denmark, that has now a sort of a recommendation for all health service organizations or all health services in Denmark to work towards organizational health literacy. And that's had quite a lot of impact. I'll not dive much into it in this presentation, but feel free to ask. I guess most of you are familiar with the concept of health literacy, but the one or the way we think about health literacy is inspired by the International Union for Health Promotion and Education, and they had a sort of a statement. They had one back in like 5 or 7 years ago, and they have this newer one from 2023 stating that health literacy is the combination of personal and community competences, the knowledge and situational resources needed to make informed decisions. So as such, health literacy includes the capacity to communicate, assert, and act upon these decisions. So of course, for those of you that are not that familiar with health literacy, it's very important to say that it's a combination of the personal resources and the context that you're in, and that could be the community competences, the family competences, and so on. So also the situational resources are very important for your ability to act. And then we work actually more and more with health literacy responsiveness. And that is the way in which services and organizations and systems make health information and health services and resources available and accessible to people according to health literacy strengths and limitations. And obviously, the reason why we work with health literacy responsiveness is that we, by changing resources and health services and national services and so on, will reach a far bigger population than when we have this more individualized focus. So taking this into digital health literacy will of course be working with the responsiveness would be to really make the access to digital services very easy, and the use of it and output of it and so on. And why, just a little bit about why has health literacy become such an important work in health promotion. We do face a lot, and I think this is not locally Denmark, this is globally. We do face some major current and future public health challenges. The world of today is very different from when the concept of health literacy was first introduced. That was actually more in a context of clinical settings, and you should have a high health literacy to actually take the treatment you were recommended and so on. But today the concept has evolved also because of the time we're living in, and we have brought it much more into health promotion. And why is that? That is because you all know the context or the commercial context of health and healthcare have really developed. The digitalization, of course, and all the new technologies, and that is exploding also because of AI. Then we must say also globally, we have an increasing social gap in health and healthcare, and that is even due to the fact that a lot of us have focused on social inequity, but there's a lot of contextual factors that actually make this social gap increasing. And then there's also from populations increasing demand for information, but also that is because that there's an information overload in many ways, and there's a lot of fake news going on that we need to work or face. There's increasing complexity, and then there's this trust crisis regarding institutions and organizations. That's just some of the public health challenges that I can mention. Of course, there's a lot more, and I know it's also a problem in Australia, for instance, shortage of staff. There's a lot of issues around health services that will change quite rapidly, I guess. In that respect, we really think addressing health literacy is important. And just to make a little summing up of what I said first around the contextual and the personal ways of thinking. So health literacy is sort of the balance between the person's skills and abilities and the demands and the complexity. And that also means that we can work, of course we can, and we should keep working on an individual level, improving individual and population health literacy through education and training. But we can also, as staff, compensate for low health literacy or challenged health literacy by improving communication and facilitating understanding and so on, as I just mentioned. And then the health literacy responsiveness would be to improve or to actually reduce the situational demands and offer institutional support. So there's a lot of actually hope in working with health literacy, because there's a lot of ways to actually approaching this. One of the sort of understandings that I'm really myself and our research group very aware of is the fact that we also should work with health literacy in a life course perspective. And I guess those of you who work with a life course perspectives would probably know this way of understanding it, and knowing that you would know that we actually, all of us, or all populations, accumulate positive and negative issues around our whole life course, and thereby also on affecting on health and well-being. So health literacy would be affected of good support or bad support, and thereby also affect positive and negative effects on health and well-being. And we work, I'll show in a minute where we work specifically around this, but this is just to illustrate what I mean by a life course perspective. We did a paper sort of working on a very theoretically hypothetical understanding of this. And one of the, I'll just show you one figure from that paper, because this is a hypothetical development of how we could understand various domains of literacy, not just necessary health literacy or sub themes of health literacy, you could also say. So one could imagine that for instance, if you look into the reproductive health literacy, or the understanding of reproduction or fertility and what is important and what is not important. It may not be all that important in the early years. It's the gray line here you can see, but it may be very important when you come up in the 20s and especially when you go in the 30s and 40s and so on. And you could also think that food literacy is really important in the very early years, or food literacy around the child is very important. And then it may actually, it's probably quite important all over the life course, but again, this is just a very hypothetical understanding of that we may be important for us to work with different sub themes of health literacy in different life courses or different parts of the life course. And why is this interesting? I think it's really important and interesting because if we look into this next figure, which is a little bit maybe crowded, but I use it a lot because I think some of the big public health issues are obesity, overweight, diabetes. And I work a lot within the field of especially gestational diabetes. And if you see this figure, if you look at the mother, obviously we know that her pre-pregnancy obesity will maybe also, she will maybe also have an excess gestational weight gain when she's pregnant. That may lead to gestational diabetes, that may lead to type 2 diabetes. Obviously, depending on the postpartum weight retention, she will again next pregnancy go into the pregnancy with obesity. But this is not something that only affects obviously the mother, it also affects the fetus and to a large extent the child. We know that women having gestational diabetes also their offspring would have a very high risk of type 2 diabetes and also a higher risk of CVD, cardiovascular disease than other comparable offsprings. So especially in this part of life around even antenatal care, pregnancy care, and postpartum care, or preconception care even, is really important for understanding what's going on according to health literacy responsiveness and health literacy. Obviously also in earlier life, but this is really where you have this kind of plasticity that can actually make your health change over the later life. So in this context, we will be working towards our next projects and so on. And this is actually my handing over to Maiken to tell a bit about her project, because we have been diving into understanding especially those women those persons that are pregnant. So this is my sort of flying into how we work and understand health literacy as a really important health promotion skill. So yeah, this was my presentation for now, and I'm happy to take questions or discuss this. So I think I'll just stop sharing actually.
Thanks,
So,
Helle. Has anyone got any questions for Helle before we move on to the second part of the presentation? Helle, are you specifically working on interventions to improve organisational health literacy? Is that sort of the main area of focus of your work?
Yeah. I mean, as I showed in the very first slide, we could never only work there, because we also need to have a strong epidemiological understanding of what is the public health challenges that we are facing and so on. But we don't develop interventions where we only teach or do patient education to improve people's health literacy. And the way we work with organizational health literacy is it's to some extent inspired by system thinking. It's also inspired by some of the work that Richard Osborne did within his Ophelia process. Some of you may know about this. It's quite a comprehensive way for organizations to understand the support they are giving. We have developed a brief co-creation process that we work on according to developing support organizations developing their own sort of taking the urgent steps first, or the steps where they're most motivated, and then we support them to make a long-term plan for what could the next step be, and so on. So it's very co-creation driven, the way we work with organizational health literacy. There was just a question in the chat around AI, I think it's called.
Yes.
Yeah, I mean that is a huge thing. A good thing about AI, we just did a study in a European group around who would people, if they have a health-related question, would they use their own sort of doctor or AI? And that was we had some really interesting findings. It was not a big study, but it was conducted in 4 countries. Stigmatize, diagnose, or problem, especially if they felt very vulnerable. And I also think people that were having obesity were more likely to go to AI, and that's important knowledge, because they think they're in a more, or they are probably also in a more neutral room where they can get information that are suited to them. That was one positive thing that AI can be used for. And also we have in Denmark, we have a very extended, we have a lot of folks on diabetes. Bodil will know that. We have some very strong regional diabetes centers, and they have set up a chatbot for diabetes, or it's called Diapod. And they have actually two levels of information. They have a level for people with low health literacy. So it's more simple information, and that is, I mean, that's the huge potential I think there is in AI. And then of course there is the backside of the coin, according to misinformation and according to who's actually behind the information that is built up. Because what they've done at these Steno centers is that they only rely, all their answers would rely on the evidence that they have collected themselves. So there's a sort of a evidence base behind all the questions and all the answers that are given. And that's possible to, and therefore I can say, okay, I know these people, they rely on heavy research. I would trust what they do. But obviously we all know that, or actually we don't know who is behind all the generated knowledge that are coming out. And we know that it can be misused and it can be fake news. Or fake information. So I think therefore e-health literacy is so important in order to build up people's capacity to judge the knowledge that they receive. Sorry, I didn't. Oh, there's more chats here. I'll just yeah, adding note. And in an acute hospital environment, is most time. How do we show the economic value and convince our funders of the? Yeah, I soon hand over to you, Maiken, but I think, Lauren, it's a very important question, and I'm very interested myself in how do we actually show the value of organizational health literacy and digital health literacy and the economic value. And one thing that is really not necessarily exploding, but really developing in Denmark is a new way of understanding values, and not just as an economical issue, but also as a well-being issue, or we talk about well-being economy, and we talk about different kind of social impact economy and understanding. And I think has a huge potential, and it's really interesting. And I know, for instance, in Finland, in the Nordic country above Denmark, they have built up a public health program where they have focus on well-being economy. So that's a really sort of evolving concept that we should all look much more into, because in public health, or in also in clinical world, I guess, but at least in public health, we are of course interested in very long lives and life expectancy age and so on, but we are as much interested in good quality of life and mental and overall well-being. So that was my sort of quick answer to that, and I think that's really important for us as a community of researchers to look into the outcomes of our evaluations, also our health outcomes. What should they be? Should it be that people feel empowered, or should it be that people have a lower HbA1c? It could be both, but empowerment is as important, that people feel that they can actually, they have the robustness to actually cope with their disease or their conditions. So that was the quick answer to the very, I think economic is a huge, interesting thing here.
Great. Thanks for taking those questions, Helle. We'll hand over to you, Maiken.
Yeah, thank you. I'll just start sharing here.
Oh, I should probably just, can you? Yeah.
So just a sec. Is it okay now?
Yeah.
Yes.
Yeah, here you go. Okay, yeah. So I'm going to give you an introduction to my PhD project, which was called the Health Literacy and Pregnancy Research Study, the HELP study. This project has also been described in much more detail in the protocol, which was published back in 2022. But yeah, I'm going to give you an overview of how we designed this study and how we approached health literacy and organizational health literacy responsiveness within antenatal care. You're welcome to ask questions as we go if anything is unclear, but we can also have a discussion afterwards. But you can find the protocol if you have, if you want to dig more deeper into to this field of research. So as Helle mentioned, Richard Osborne and his group has developed the Ophelia method, with the Optimizing Health Literacy and Access method, and we applied this method within my project. It is a co-design approach, which has the objective to improve health literacy, but also equitable healthcare access. And the unique thing about this method is that it is very much focused on local data, but it also have stakeholder engagement at a large extent. And the whole, the main objective is to create tailored interventions, which are very much specifically developed for this context that they have to work within. So the Ophelia process is divided into 3 phases. And within my project, we are currently within phase 2. But we did the first phase within my PhD. It is designed in a way so that different strengths are identified within the local context, but also different needs. What are the barriers when we look into organizational health literacy responsiveness? And then it is set up in a way so that action ideas are created. So initially, we did the project setup, designed the study, and then the data collection started. The first thing we did was to conduct a large systematic review, trying to identify all existing evidence around health literacy within the prenatal period. And we identified 44 studies. What was interesting was that most of these studies was around functional health literacy, which is the women's ability to find information and read information and so on. So very functional literacy. And then there was a few studies around more interactive health literacy, so how the women communicate with healthcare professionals, how they interact with healthcare services. But there was only very few studies around critical health literacy. So there were some questions before around misinformation and stuff like that. So we actually don't have that much knowledge around critical health literacy. So how the women make decisions, how they critically assess different sources for health information. So there was quite a large gap there within the literature. Then we conducted interviews, both with women, but also with different healthcare professionals, trying to have some local data, local knowledge around how the women how are their behavior during the pregnancy course affected by their health literacy? And then we asked healthcare professionals how they experience different strengths, but also limitations within the organizational structure for them to support women with very different health literacy skills. And then the main part of the data collection was a large survey where we included the health literacy questionnaire, which is also a questionnaire developed by Osborne and his group, and it has 44 items in total. So it's quite a large questionnaire trying to gain evidence around the women's health literacy. But we also included 2 scales from the e-health literacy questionnaire, which is designed to collect data about digital health literacy. Yeah, and within the survey, we also included different questions around mental health, but also different socioeconomic demographics and so on. And then after the data collection, we did cluster analysis, and I'll show you the data or the results later in my presentation. But there was quite a lot of interesting findings there. Yeah, and I'll tell you more about how we then use these cluster analysis to create case profiles. So what is the main thing about these cluster analysis is trying to look into different subgroups within the study population to identify different skills around health literacy and digital health literacy. Then what we just did was to present these findings and these case profiles to different stakeholders at stakeholder workshops. So we invited a lot of different healthcare professionals working within antenatal care and then presented these cases and asked all the healthcare professionals and the participants how they would go about these different skills, but also and strengths, but also the different limitations that the women experienced. And then a lot of different action ideas was created, organizational action ideas. So actually the different healthcare professionals take on how to address these different strengths and limitations that women experience within the organizational setting, so within antenatal care services. Yeah, so and what we are currently, as I mentioned, moving on to phase 2. So the different action ideas has been discussed within with different stakeholders as well, and we're trying to create a logic model, a program theory to set up the intervention with all these different organizational change ideas that we are trying to implement. And then we'll move on when the intervention is developed. We'll implement and evaluate the intervention. So that will be in phase 3 of the project. Yeah. So the objectives that we have addressed so far was that we initially wanted to investigate the pregnant women's health literacy and the digital health literacy. And as I mentioned, we did so by applying these 2 measurement tools. And then we wanted to create these evidence-based case profiles, and we did so using cluster analysis based on the data that we collected. And then, as mentioned, we are just right now in the process of co-designing organizational action ideas. And the main objective is to strengthen the organizational responsiveness within this setting of antenatal care and hereby support the women in a better way, and also trying to increase access across the whole, even with women with lower skills who struggle with access, so making it more equitable. Yeah. And then I just wanted to show you some of the data that we collected among the 883 women which participated in the study. These are unpublished data. The paper is currently in review, so I will kindly ask you not to take any pictures or so, but I'll just give you a brief introduction so that you get a feeling about how we address this. So what you can see here is that we have 6 clusters, and with a varying number of women within each cluster. And then we have in the beginning here the scores on the e-health literacy questionnaire, and then afterwards the scores on the health literacy questionnaire. And what you can see is that it is color-coded. So green meaning that women within this cluster have higher scores on this specific scale, and red meaning lower scores, and they are relative to each other. And I just wanted to tap more into cluster number 5. What you can see is that they are there is none of the scales here are green, so they have lower scores across each of the scales here. But what is very specific for this group is that they have a very low score on their motivation to engage with digital services. And that is really important because, you know, coming from the organizational perspective and trying to create services that accommodate these women, it wouldn't be very beneficial to make a digital service only, because this group would not, you know, engage with it. So that's a very, very, you know, important knowledge to have. Also, they have lower scores around actively managing their own health, and also around navigating the healthcare system and their ability to actively engage with healthcare providers. So they encounter a lot of you know different difficulties that we have to be aware of. Then compared to cluster 5, we have, for instance, cluster 1, the first one up here, and they have a lot of strengths. And that is also very important knowledge, because from the organizational perspective, it may be easier to accommodate these women. Maybe, you know, cluster 1 has very high scores on the motivation to engage with digital services, but also whether they use technology to process their health information. And this is very important because, you know, there are some resources that we can get here by applying digital services to this specific group. And these resources can then be used for the groups who struggle with these things. Yeah. Then what we did based on these clusters that we identified was that we made these case profiles, and this is also cluster 5. Based on the data that I just showed you, we gave each cluster a title, a very informative title. So you can read it here, but it just says that you know, what are the specific group struggles and what are their strengths according to health literacy and digital health literacy. I just wanted to mention that what was actually also very interesting during these cluster analysis was that when we looked at the health literacy scores and the digital health literacy scores for the entire study population, looking into the means, we actually saw that for this study population, scores were quite high. So they, you know, making concluding based on the mean scores, we would say that this group was actually quite skilled. But then looking into the clusters, we found that this was not true for all the groups, and that's, in my opinion, very interesting when we have to tailor interventions to different groups of people. Yeah, and I just wanted to mention some of the characteristics which was also you know which applied to women in cluster 5. So they were on average 31 years. And 15% of them did not plan their pregnancy. That's also very interesting knowledge. Cluster 5 was also characterized by the largest percentage of women who were from another European country compared to the other clusters. They had they experienced to have social support for health, but they struggled with their ability to actively manage their health and also the ability to navigate the healthcare system. They also had lower scores on scale 1, which was the one around whether they felt understood and supported by healthcare providers, and also scale 6, which was the ability to actively engage with healthcare providers. So this indicating that they had problems related to this interaction with the healthcare professionals. They also struggled with their motivation to engage with digital services, as I mentioned. Yeah. And just to give you a bit of information about what we are currently doing and how we are moving forward with all this new knowledge that we've gained so far. As I mentioned, we just had these stakeholder workshops, and we are in the process of developing the intervention. And for now, we have 9 very context-specific organizational change ideas. And these were, as I mentioned, developed in collaboration with the stakeholders. What we are planning to do is, or what we already are doing, is that we are trying to, to do a collectively core outcome domain set around organizational health literacy responsiveness, because so far there's been a lot of different ways of talking about organizational responsiveness and a lot of suggestions of different domains that are important when we address organizational responsiveness. So what we did in a group that I was also part of was to within the literature to identify all the different outcomes that are used when looking into organizational responsiveness. And we pulled these outcomes, and then we just finalized a paper. We also did a Delphi process and had a lot of process around creating these core outcome domains, but the paper will be published soon, hopefully. And what is interesting is that we now have 5 heatings with underlying core outcome domains for organizational responsiveness. How do we address organizational responsiveness? So that is underway, and we'll be using that within my project. And I can just show you here. As I mentioned, we did this literature review, and it identified actually 383 different outcomes. And then we did this, we did a content mapping process and ended up with 26 proposed outcomes. And then the Delphi process resulted in 15 core outcome domains in total. These are also unpublished, but just to give you an example of core outcome domains for organizational responsiveness, this is around person-centered care and user involvement. And then we have these 3 underlying core outcome domains out here. Then after this process, we had a lot of discussion around how to measure and how to assess these different, outcome domains of organizational change. So what we are currently doing is that we are trying to develop an assessment tool. A lot of work has already been done, among others, within the MPOL network that some of you may know. But we need, high quality measures and ways of assessing organizational responsiveness. And we just received some funding to go about with this process as well. So within my project, and what I'll be doing within my upcoming postdoc is to within the HELP project to implement the intervention that we developed, and then also doing a large-scale assessment, both a baseline assessment of the organizational responsiveness, and then also having the possibility to measure any change within the organizational responsiveness after implementing these different action ideas. So that is where we are currently at. I'm very much looking forward to see how these different ideas and different organizational changes will hopefully help improve the organizational responsiveness within these antenatal care services, and also hopefully help bring down social inequity within these women's access to the different services that we have available for them. Yeah. I think I'll stop here and save some time for questions as well.
Fantastic. Thanks, Maiken, and congratulations on a huge body of work for your PhD and for sharing with us, some really interesting ways that we can start to think about how we might tackle the issue of poor digital health literacy amongst older people in the rural and regional context. Questions for Maiken or even Helle? No? Maiken, I am curious, in terms of you really clearly described the process, which was great, and emphasised how it's been a co-design process from the beginning. In terms of the conceptual, the initial identification of the problem, did that come from your stakeholders? So one of the goals of the Deliver program is about strengthening collaboration between health services and academics, and we've really been trying to work to understand and uncover local challenges and issues. What was some of the early work that you did to arrive at your study?
Oh yeah, definitely. We didn't have initial conversations with these specific stakeholders, but actually, yeah, the project that we are conducting at the moment is within in collaboration with a Danish municipality, so the healthcare professionals working there, and also the hospital as well. So intersectoral. And they actually reached out to us. We have a lot of different healthcare services reaching out to us, also because of what Helle mentioned. We did this large work with the Danish Health Authority around and created a large or a report around how to implement organizational health literacy responsiveness within a Danish healthcare setting. So because of that report, we have had a lot of different healthcare services, organizations, but also healthcare professionals and the managers reaching out to us and trying to have a conversation with us around how can we go about this within our organization. So we do a lot of different processes. Actually, we are out there trying to help set up these different processes within local organizations as well. So within my project, there's been a lot of outreach from this specific group of healthcare professionals and the managers within both the hospital, but also especially the municipality. Actually, yeah.
That's great. And so then your pathway to translation, hopefully much quicker than sort of what's happened in the past. And how do you manage the discussion around the timeframes? I mean, that's a huge body of work, and that's taken years, obviously, to get to the point that you're at now, and you're now in another sort of co-design phase. How have you, managed that with your stakeholders?
Yeah, thank you. That's a great question. Well, one of the main barriers actually that I encountered in the beginning was that as this was planned, we Helle and I and others had a lot of great dialogue around that. What we really wanted was to really gain a big pile of knowledge around this local context. Because we think it's so important when we create these interventions that they are locally nested. So we really wanted to, have a lot of focus on understanding what is it, which context, and what are the organizations that we want to tap into, and so my PhD ended up being only around phase 1 of the Ophelia, and it was quite a large barrier to receive or to have funding for that, because many of the different funding bodies wanted to, have other results, have the intervention outrolled within the project. But we really wanted to make sure that we didn't just, make an intervention to make an intervention. We wanted to make sure that this was actually necessary and that it was really tailored within this local context. But there was a lot of discussion around time actually, and how to address this. I think that and I hopefully it will end up really having an impact, because we did a lot of work to really trying to understand the local context.
Fantastic. Thank you. Anyone else with a final question before we close the session?
Yes, I have a question. Thank you for the great presentation. I wanted to ask, I think you might mention that, but I was wonder if the whole project is for a PhD or just the phase 1 is for her PhD, or after that she will doing the other phases in her postdocs or something, because I think it's a huge, it should be a huge project.
Yeah, definitely. So you're absolutely right. I did phase 1 within my PhD, and then we'll move on to the other phases within my postdoc. There are examples of applying the Ophelia method in a much smaller scale, also depending on how many, what are the group that you want to address. Is it a small group, or is it, pregnant women in Denmark is a rather large group, and there are very many different organizations and stakeholders involved within the services surrounding pregnant women. So it always depends on whether the goals, but also what are the context and how what do you want to get out of the project. But yeah, you're definitely right. This was a very large project that we so within my PhD it's been mostly around phase 1 and then going on to phase 2 now.
Great, thank you. And the reason why I was curious is that I'm working on dementia literacy, and it's somehow relevant to health literacy and organizational literacy. And I was curious about the timeline,
Yeah.
Thank you very much.
That's great. Thank you. Well, thanks very much, Maiken and Helle, for getting up early and making the time to present with us. If those of you who were here at the start would hear that both Helle and Maiken are adjuncts at the Institute for Health Transformation at Deakin University, so close friends. And so we can reach out to them if you've got further questions or thinking about, how you want to tackle this problem in your own work. I'm very happy to help connect. So yeah, thanks very much. And we've learned a lot. Enjoy the rest of your day.
Thank you for the invitation.
Pleasure. Bye, everyone.
Bye.